And there's the proof. The recording is now in progress. The recording will go on our website later. Could I ask you to stay on mute, please, so that everybody can hear as clearly as possible, but do put any questions that you may have in the chat box. Just to let you know, I'm currently working on our workshops for the coming 6 months or so, just devising the subject matter, and I'd welcome suggestions from all of you on subject matter. Our aim is to meet your needs, so do tell me what they are. I also want to remind you of the work we're doing here at Care and Support West on the Better Security, Better Care project, and how we can support you to complete the Data Security Protection Toolkit. Do look at our website. There's a special area for it, and there's a webinar tomorrow morning. You'd be most welcome. Also, while you're there on our website, there are only a few, but there are a few tickets left for our fantastic awards evening on the 9th of October at Ashton Gate. We're very much looking forward to a night of celebration in a room with people, which would be lovely. So on to today, we welcome back Saffron and Natalie from AHSN with an update. Sorry, I'm going to let more people in. Right, that should be done. So start again. We welcome back Saffron and Natalie from AHSN with an update on Restore2 that you, I'm sure, will all remember from March this year. We promised we would do an update, a follow-up on that. After them, I've invited Wendy Smith to do a further follow-up on the clinical placements workshop we held in May. And yes, everybody, nurse placements in social care do remain crucially important, and we need care providers to welcome clinical placements, and we need lots of them. Following that, we've got Louise from our Commercial Partners Nourish Care, who's going to talk to us about how they have helped 5 care homes improve their CQC ratings, which I know will be of interest to all of you. And then, by no means least, we have Sian Walker-McAllister to update us on safeguarding. We've titled it Reassurance, Reminder and a General Refresh. So I'm sure we're all looking forward to that. So I'm going to go quiet now, and I'm going to hand over to, I think it's Saffron, with the support of Natalie, on Restore2. So over to you. Thank you both.
Hi. I'm just setting up the screen sharing, so bear with me. Always takes a little while. So hopefully you can now see that on screen. Can everyone see that? I can see a thumbs up. Thank you, Lewis. So yes, thank you very much for inviting us to present. I know my colleagues Sandra and Hein came before. We're going to start with a little bit of a refresh, just to remind you about who we are and what we do, so that you've got some of the background. And then I'd love to hear a little bit more from you about how things are going. Angela, it'd be great if you want to give us a 5-minute warning, because I know you've got a very packed agenda today. So feel free, if we're running on over, to let us know.
Will do.
Keep us to time.
Will do. Thank you.
So I'm going to hand over to Saffron to start.
Hi, my name's Saffron Reevely. I'm a GP in senile surgery in North Bristol, and I'm also a primary care clinical lead for the West of England Academic Health Science Network. So Restore2 has been going for a few years, but in Bristol it's been a couple of years now. And of course, that covers things that you're already doing. I think that was a sort of important thing to say, that most of you in the homes, I think, have been doing this for a while, especially with COVID, the observation side of things. Most homes are doing observations. You've got some of the equipment now. So it's really just formalising what everyone does in a way so that everyone provides the sort of same level of handover and same level of care for patients. So it's recognising the early soft signs, it's taking observations, and it's sort of acting on those and escalating as appropriate. And it does encompass respect as well. So I'm not sure if everybody's from, some people maybe from outside the Bristol area, but in Bristol and North Somerset, South Gloucestershire, we use Respect, but there's other plans that you might use elsewhere. So it's just to try and make sure that we don't miss sepsis, we don't miss treatable things, that people that are in care homes aren't disadvantaged by being in a care home, that they get the same kind of escalation or help that anybody else would get, even though we are their voice, or the carers, or you people looking after them, do provide that. So sort of on the next slide, I think we're going to go through a little bit what the different steps are. So there's 5 main components, as I said. The first one's recognising the soft signs, and you're probably quite adept at doing that, and it's just what's not quite right about your resident and what might make you think maybe things are not quite right with them, and might prompt you to do some observations or look a bit deeper or ask some questions. So I think in terms of what's normal for the resident, that's something that we're sort of trying to emphasise, because that's really useful, especially as a GP receiving calls. Knowing what this resident is normally like is key. So if they're normally bedbound, or if they're normally mobile around with their Zimmer and they come out for lunch, you know, that's really important to give us a picture of what's normal for them. I think some places, if you're a care home, you may not be calculating news scores, particularly you just be doing the observations. And really the key thing is the observations help us, but it's also what's normal for the resident in terms of their observations. So especially with COVID, we have seen people with lower SATs for a period of time after COVID. And so normal for them may not be strictly normal, may not be a news score of 0, and that's okay. So it's kind of comparing normal for them for what they're scoring right now. That's the more important thing. So news score, again, if you're a nursing home and you've done the Restore2 training, the full training, you might learn how to calculate a news score, and sometimes the paramedics will ask us about that, and it just gives a really good picture in one number as to how ill someone is. Certainly if I'm a GP and I'm having a call and someone says the news score 6, I'm like, oh, okay, I might need to call them sooner. Of course, if their news score has not been normal to start with, because they've got COPD and they have low SATs, or maybe they've got heart failure and a low blood pressure, that changes it slightly. But it just would make any health professional, I think, prick up their ears a little bit, and perhaps you jump ahead on the call list if I saw that in the summary. So it doesn't matter what the news score is, and certainly if your staff are not like happy calculating news scores, it doesn't really matter. It's the observations are key, because we can do that quite quickly anyway. So the most important thing is the observations, taking those next steps. And then if you're worried, if you think the observations are not quite right, or they are abnormal, or the news score is up, to just communicate that. So usually that's going to be a call to a GP, or if it's like a stroke or a heart attack and that person wanted on their Respect form to go into hospital, then you'd be looking at calling an ambulance. But increasingly, certainly in Bristol, North Somerset, South Gloucestershire, we've got the 2-hour Sirona response now, maybe different outside areas. So there is alternative to ambulances where people can be seen quickly if they need to be, if they're more poorly. And so the SBAR tool is something that's been used in hospitals, and if any of you've done the training, I think quite a lot of places have done now, you'll be familiar with that. So that's just a good way to communicate to any health professional. The paramedics use it, hospitals use it. GPs are probably less good at using it, actually, but it's just standardized. It gives you a little bit of confidence. So you do a summary of what the situation is, a little bit about the background of the patient, and that will be what's normal for them, and what their normal scores would be, your assessment, and then a request or recommendation for what you want help with next, or what decisions you're going to make in terms of the management plan going forward. So yeah, it's just about getting the right help, the right time for that person, first time really. So next slide, please. So these are a bit more about the charts. So Restore Mini is the one on the right there. You may be familiar with this. It comes with the packs if you've done the training, and that's quite a nice summary, because it just goes through the soft signs, the main ones: breathing, drinking and diet, shiver and fever, off legs. And interestingly, that's a slight update, I guess, since COVID, because those purple signs are the ones that might also indicate COVID infection. I think now you're doing so many tests in homes, you're not really missing COVID. We've got testing now, so it's slightly changed from the beginning of the pandemic, but it's just remembering to think about those things. And if you've got some of those coming up and it's unusual for your client, you'd be thinking, okay, I need to do some observations and I need to sort of take this to the next step. It might be if it's just low level abnormal observations, you just repeat them. But if you did need to speak to someone, you've got the SBARD there written down on the other side. You know, what's the situation? How are they now? What's their background? What's their normal? What were your observations? And then what's this? What decision do you need to come to? You know, if there's something you want, you know, I need to know whether to let the family know. I need to know whether they need a visit, or that's what you need to clearly communicate your needs. And as GPs or health professionals, we need to kind of give a satisfactory answer at the end, I think. So that's the Restore Mini on the right. On the left there, we've got just the adults observation chart. These charts come with the training, but you don't have to use the charts. Restore2 is not about using the charts. Some of them are quite lengthy. Other care homes do have their own systems for inputting observations or inputting the things they do on the patient. So I know it's not an absolute. You can still be doing Restore2 without using the sheets. They're just guides. They're just something that was used in the original pilot. And if they're helpful, you've got them. They're also available online, so you can print out more if you want. And they just give you a guide. And I think the news score is also just a guide to sort of have a feel for what observations are normal or what aren't. I think now you've been doing them for a while, you probably have a handle on what's a low saturation in your oxygen, what's a low blood pressure, but they just give you sort of some reassurance as to what's normal and what's not. But it's not essential to calculate the news 2 score. If you can, that's great. Next slide, please. Yeah, so respect comes in really when you're presenting with the SBARD. So you said the situation, like the patient's got blood in their urine at temperature, for example, and then you're giving the background. I think that's where we really wanted to highlight. Now, respect is most patients that come to care homes and most patients that are discharged from hospital do end up with a respect form. It's really, if you're in our area, if you're outside Bristol, North Somerset, South Gloucestershire, and you're not using respect yet, there may be other sort of escalation plans that you're using instead, or a CPR recommendation, for example. But it's really useful to have that there, because obviously if the patient doesn't want to go to hospital, you're going to do things slightly differently, but you might still be able to offer treatment, but not hospital treatment. And of course you can still ask them. So although the respect form, it documents what they are hoping for and what it's slightly different now. This is a respect 2. There is a version 3 which is available in the GPs now, and the hospitals are doing the version 3, which looks very like this. It's a purple form. It's just got some middle boxes, which is kind of the middle ground. So and it's using slightly more patient-friendly language. So it's supposed to be written in the language of a patient so that they could understand it, or their relatives could if they were to look at the form. But yeah, the respect form will document what the patient would want if they were too unwell to express their wishes. But if they are completely with it, we can still have a conversation with them. It's not like if they've said, I never want to go into hospital, and then something happens and actually they say, oh, actually, I really would. We can still let them go. So it's not legally binding document. It's a guide, and it's mainly for when people can't express their own wishes. So it's not set in stone. And sometimes you might say, oh, they're in absolute agony with this fracture. You know, they said they didn't want to go in, but actually they really want to now. And that's absolutely fine. So it's not set in stone. It's quite flexible. It's mainly a guide for when their voice isn't there and we can't listen to it. But what their preferences would be is important when we decide what plan we're going to make to escalate if they have got some abnormal scores or signs of an infection or something like that. And next slide, please. And I think it's over to you now, Natalie.
It is. Thank you, Saffron. So we've got lots of resources available to support, because our approach has always been with the Restore2 training that actually you know all this, you know it in your homes, you've got a lot of experience. It's really sometimes just packaging up in a way that makes it easy to remember and easy to train new starters who may be less familiar with things like this. So some of the things we've got are some videos, free videos. They're all 3 or 4 minutes long at most, and they break down all the individual bits into different parts of the package. So if you've got someone who's really good at everything, but actually you think they just need a little bit more understanding of structured communication, there's a short video about that. Or if you look after people with a learning disability, there's a short 3-minute video about recognising deterioration in people with a learning disability. So they're short, they're bite-sized. You can also just watch them if you're going to be measuring a blood pressure and you think, oh, I'm not quite sure how to do that. For a new member of staff, you can take 3 minutes, quickly watch it, and then you go, yep, I know now, I'm happy and confident to proceed. So that's the aim for our resources, been things that are bite-sized that you can just use as you need them. Locally, we've also provided training in Restore2 Mini, Restore2 Full and Train the Trainer. And we're looking to increase our Train the Trainer offer so that you'll have the accreditation to deliver this yourself for new starters. We've recently done a national commission to provide support to carers of people with a learning disability. And we've provided training in collaboration with Bristol Mind, and I should say, in wellbeing and support for care home managers. And we've had nearly 200 care home managers go through that as well. And we're doing some support around workshops for paramedics at the moment, because we know they're the people who are coming to homes and having to make decisions. So that's it. All our resources are available on that link. And if I just go on to just a little bit about where we are and how we've got on. So we've trained over 2,000 staff from 200.
If I could, sorry, it's Angela, Natalie, if I could ask you to speed up, we're running quite a bit behind time now, I'm afraid.
That's okay. So just to let you know, that's where we are. So thank you to everyone who's been getting the message out. If you do want to come along to training, then do get in touch. I'm going to skip over these because we'll send the slides out afterwards with all the details in here. So yeah, that's just our contact details and our link. Thank you very much.
Thank you so much. That's great. If I may, what I'll do is I'll add the slides in onto our website in the resources page, and then people can pick it all up from there, which would be superb. So thank you.
That would be lovely. And I'm happy to stay on for 5-10 minutes if there are any questions people have in the chat.
Perfect. Thank you. I'll let you keep an eye on that. What I'll do now is hand over to Wendy Smith, and she's going to talk to us about clinical placements in social care. So Wendy, 5 minutes, please, if that's all right. Thank you.
I'll do my best. 5 minutes. That's wonderful. Okay, so I'm Wendy Smith. I'm a nurse working with the Training Hub, and there is a project with Health Education England to encourage students to have more exposure to social care. As a nurse, I know the wonderful work you do, and as you know, the Restore shows that you are massively trying to encourage your workers to make decisions about people's care, and we want to expose student nurses to that. Do you have the slides, Angela?
Yes, I do. Would you like me to do that?
Just very quickly, only maybe the contact details. So we have over 370 trained nurses in social care, but yet we probably only have about 20 placements that are active. So there is this slideshow, which is quite amazing because I've done it, about what the benefits to organisations are to building your new workforce, because we know that the workforce needs to be developed. So without the positive exposure to social care, it's unlikely you'll have talent for the future. So I am just trying to move it forward. Sorry, Angela, would you be able to do that for me? So to have a student, you have to have an employed registered nurse. However, that hopefully in the next year will change. We're trying to bring other models, because it's not just nursing homes that students need to be exposed to. It's residential homes, it's home care, dom care. It's the whole spectrum. We know that hospitals do a very small part of the work. And when people are living at home, we want to help them live healthier. If you could go to the next slide, Angela, that'd be great. So the university provides training for your nurses, and actually, hopefully in the future, to your carers to be able to support students as well. But at the moment, it's a registered general nurse, And it doesn't matter if they're the registered general manager, if they're happy to take students, there is a small financial recompense for this. So the tariff at the moment is £100 a week. And the qualification isn't a formal. It used to be a university-led with a qualification, but it's not now. And the next slide, Angela, please. So to engage your future workforce and to the opportunity to showcase the variety of employment opportunities for registered nurses in adult social care, come next slide, there are two people for you to contact, me and Kim. I'm more than happy to discuss any questions you have, whether you would like to pitch for the future about having social care, have student nurses. And, you know, let's be honest, things like Restore, you know, the observations, making these clinical, it will help your staff to develop those skills. And it, you know, all of these things seem very separate, but it's not. They're very integrated, and it's really important that we all recognise that without that integration, we're not going to move forward with giving people the skills. And, you know, who's going to look after me? Who's going to look after you? That's what I want to put forward. So please email me. I'll stay on for 10, 15 minutes after this. There are no silly questions. There are just questions that need to be answered. And I'm more than willing to open dialogue. And I really appreciate, Angela, you inviting me to this. I without the help of Care and Support West and Skills for Care, I would really struggle. So there's my pitch. Did I do okay on time?
You did. You're brilliant. Yes, you can come again. Thank you, Wendy. Again, as I said with Natalie and with Saffron, and thank you to both of them. Excuse me. I'll put your slides up as well on as a resource on our website. So thank you very much. And you're all very welcome. It's great to have you here. I'm glad we can help, but we understand at Care and Support West just how important it is to get nurses interested in social care and see it as a career choice. And it's something that I'm quite widely known to have a passion for. So thank you. So on to Louise. I'm hoping you're going to be able to do your own. You can. Marvellous. I can sit back and breathe. So off you go, Louise. Thank you very much.
Thank you, Angela. Good morning, everyone. My name is Lewis. I'm from Nourish. Today, with only 15 minutes, of course, we will share the slides in the end as well, but we try to share some perspective on how CQC sees sometimes a digital care planning system, such as Nourish, being implemented in a home. We have been getting a lot of feedback recently from people saying they were actually recommended to use Nourish by consultants or by CQC. So we thought it would be good to show a couple of examples of that. So in a nutshell, Nourish is a digital care planning system, as you know, as a lot of you know probably. We are currently implemented in around 1,800 homes across the UK. We support not only care homes and nursing homes, but also domiciliary care, mental health, reablement, learning disabilities, because we try to be a bit different from the typical digital care provider by offering a lot of personalization. So actually, it's not just a piece of software, it's actually a consultancy service almost, where we sit down with you and we try to understand what are the issues that you currently have, and we can adapt the system to that, and that can be adaptable at the service level as well. So we try to do that by offering handsets to any floor staff. So anyone who is with the resident can input information very easily, and then that can be seen on a tablet, on a computer, for instance, by the managers, either on site or remotely. Let's have a look at the first case. The first case was a home which had a very high number of falls, and they asked us, is there anything that we can do to help? So the first thing that we always do is the input of information. So just like the previous presentation we saw, the first one, you can input on Nourish things like the news, like the Restore as well. So it's making sure that there's the habit of inputting that information, because the most important thing is start with the observation, start with the inputting of information so that you can actually start looking at trends, for instance. So what we've seen was that the number of falls was happening mostly at night. And the cause of that was the carers were looking at the daily fluid intake charts and almost trying to reach the target at night. So what was happening is when they got to the night staff, they were giving the residents, they were offering too much to drink, let's say, and the residents were waking up at night and they were more prone to falls at that time. So by having that perspective and trying to take a step back, we implemented a warning system, let's say, for hydration monitoring, so that we would trigger the carers to offer any fluids throughout the day, and mostly in the morning rather than in the evening. With that warning system, if people did not reach 25, 50, 75% until maybe before dinner, that would trigger a warning on the handsets, and they would know that they had to offer a drink. So what we saw with this was, by doing the fluid and hydration monitoring, there were warnings that told them what was the progress happening throughout the day. The hydration levels shifted to early hours, which led to fewer night visits to the toilet, which ended up with a reduction of falls. So very quick case, just to give you an idea of how digital can help compared to a paper system. In the second case, there was lack of accuracy in quantity of notes. So the home was lovely, the staff was lovely, but there was a struggle in inputting information, especially with the lack of accuracy. We saw a lot of carers waiting until the end of the shift and then inputting the information almost as a second guess. They didn't know whether it was a tea or a coffee that they offered. We actually observed this. The carers wouldn't mind inputting the wrong information because they didn't realize the importance of it for what they would think were basic elements of care. So we tried to introduce speech to text. So speech to text was what you might think it's gimmicky, but it's actually a rare case where you increase the quality and quantity of information. So even if you struggle with with English as your first language, that actually reduces the errors in inputting qualitative information. So anything about mood, behavior, cognition, for instance, no spelling mistakes and no grammar mistakes or punctuation happen after that. When inputting group activities as well, we found that if you have, for instance, a care home with 40 residents and everyone goes to a Christmas party, for instance, you have to input the information 40 times. But with Nourish, you can actually do it as a group. So you could incorporate everyone within the same note, and that automatically populates each person's care plan. And with the handover as well, we found out that by introducing the concept of timelines, which is what Nourish does, you don't have to rely on a handover. You can actually come back after a week, after a month even, and then you could look back in time and see what were the critical things that you missed. So this was a case where inputting the speech to text, pre-populated notes as well. So for things like what are the activities that you like to do, and it would automatically tell the carers what are the activities that were relevant to that person. The group notes, as I just mentioned, and the handovers, there was actually a massive improvement in quality and quantity of notes while saving time at the end of the shift, because the carers didn't have to spend that 30 minutes, 40 minutes at the end of the shift writing down the notes. On the third case, there was mostly poor communication within the home. So this was more like a diagnosis rather than a symptom. But what we saw was that with very simple introduction of things like labels for critical information, so something like DNAR, dolls, allergies, even COVID-19 tags, it was very easy for the residents, for the carers to instantly see what was the key critical information around the residents, rather than having to look at paper notes, for instance. Another example was the family portal, the circle of care. So actually involving the GP, involving the family into the person's care remotely, so they wouldn't have to give a call or visit the home in order to comment anything around the care plan. Or the messaging system as well. So with the messaging system, you can tell whether someone read the message. You can set to groups of carers by their roles as well. So not necessarily to all the carers, but only specific people you want to receive that note. So critical information became clearly visible, so people would be more proactive rather than reactive. The handover and warning systems actually allowed for visibility information at a higher level. They won't have to do it on a case-by-case basis. The messaging system for staff really changed by taking down all the notice boards or not knowing who read what message. It was an actual triage system, so you would know who was reading the message. The family portal involved the families, even if they were very far away. You would always know what was happening on a daily basis rather than every month. And GP Connect and the eRad Bank is not directly related to this, but it's an example of how we can improve communication by linking directly to the GP notes or linking directly to hospitals, so the hospital don't have to give you a call. The ambulance crew doesn't have to wait for the eRad Bank. They can just access it online, basically. On the fourth case, obviously the COVID-19 pandemic, every report last year was mainly around what were you doing in terms of infection control. So the things we've seen that were used in the most creative way were basically, well, stationery and paperwork is the most obvious one that massively reduced infection control because you don't have to share paper, you don't have to share any stationery. You would use an input and access any information from one handset, your own handset, so you wouldn't have to share them. But a very creative way we've seen it being used was to use NFC tags, just the ones you use on contactless payments nowadays. You could actually link them to any notes that you were writing on Nourish. So you can use it for things like night checks, things like turning and positioning, medication key handovers. All the carers had to do was swipe and just say that that was done. And this home used it in a very creative way. They've actually used it for items that had to be cleaned. So they would tag the items and then they would be cleaned and automatically reported that that has been done. So it just shows the flexibility of the system of how you can actually be more creative and go beyond just the care side of things. So in the end, it really helped with obviously remote monitoring. If you have a cloud-based system, you don't have to have it on premise. You could be right here and seeing what's happening in the home remotely. Reduction of paperwork and stationery, which drastically reduced infection rates in the home. NFC tags for cleaning routines, as I just mentioned. The family portal, again, really helped with throughout the pandemic because it gave the reassurance to the families of what was happening rather than obviously not being able to visit the home. And COVID badge, just like the labels I mentioned before, you could use it for COVID as well. So you can track down vaccines, you can track down symptoms, tests, and just have the full workflow of information. And for our final case today, we actually had a very large home. We're talking about over 120 beds, which had lack of visibility. It almost behaved as multiple different homes within one. So when you go over 60, it starts being broken down by ward, as you know, and you start losing a bit of visibility of information. So we, early this year, we introduced the concept of Nourish Insights. So it's actually looking at all that data gathered by the carers, and it's not only the reports, but actually visibility through dashboards. So we have not only an operational perspective, but also clinical perspective on things. So this is an example of weight monitoring. So you could track the MUST assessments on how far back you have actually done the MUST and what was the score on a scale. What was the last time since you've done the MUST, broken down by person as well. A second example from a clinical point of view was incidents and accidents. So you could see specifically who was involved in the incidents, where did the incidents take place, what was the place in the home where they had the incidents, how many were witness reportables, whether they went to CQC, whether they went to, whether they had to be reported to the local CCG, for instance, the families. And finally, on the clinical perspective, slip, trips, and falls. So that's prevention of the actual incidents would be a very similar way, but it's then broken down into the near miss. So that was a higher number, but then it reduced the incidents. By having this visibility, you can then operate at the home level, almost as if it was one home rather than 3 homes in this particular instance. If you have a group of homes, for instance, you could see all this information across as well. But it was a very interesting case where the home was really struggling, and then suddenly they really caught up with everything. But the key piece of feedback we typically get is how when you are CQC inspected, you typically are scrutinized on a number of files, but not all of them. And with Nourish, you can actually see what is it that you're actually missing, rather than just having random spot checks. So it really allows you to be more proactive. And the current market sentiment of people actually saying it's actually easy to use. It's not that old fear of carers are not going to enjoy it. It is completely gone by now. We have carers actually engaging and asking if they can implement Nourish. So it's very good to see that people are finally adopting. With the pandemic last year, there was definitely a shift of trend, and yeah, that's where we are now. Obviously, it was a bit rushed. We only have 15 minutes, but I tried to keep the 5 cases in one. This is just the ones I just mentioned. And if you have any questions, happy to put it on the chat, or you can get in touch with us directly. And as Angela said, she will be sharing the slides. So I think I'm on time.
You are. Thank you very much. That was very good. Thank you. Fascinating stuff. I'm really very interested to hear about how well it's worked in the last year, especially, and how useful it's been for everybody. And just a reminder to people attending and those watching the recording, the slides will be up in our resource centre on the website. And there is also further information about Nourish Care there under our commercial partners area. So thank you very much. Any questions, do please pop them in the box. If Louise can't stay, I think Emily is still here and she can pick those up as well. So thank you very much. So last but definitely not least, I'm going to hand over to Sian Walker, and she's going to talk to us about all matters safeguarding. Are you okay to share your screen, Sian, or would you like me to be your assistant?
I'm going to actually, would you do it? Because I'm used to working on MS Teams and not Zoom, so it might be easier if you do it. If that's
I
okay.
will. Okay,
thank you. Right, okay, so hello everybody, I'm Sian Walker. I'm an independent chair of Safeguarding Adult Boards, as shown on this slide here. I've been working in social care, and particularly in residential care services and home care services, both for a local authority and the independent sector for very many years. I've been working for 43 plus years now, but I've worked across children's and adults, learning disability and mental health as well. I've done a presentation today, which I think, because I was asked to do something that would refresh. So can I ask anyone if they think that this is just repeated stuff and they know already? We'll skim through it quickly, but I'm also really happy for you to take bits of slides out and use it for the training for your own staff as well. Not all of it will be relevant because it's aimed at you guys, but there might be some bits in terms of some of the information about abuse, harm and neglect as well. So if we can go to the next slide, please. So my objectives today are to just support people in getting an overview and essential knowledge about the Care Act 2014, which is the legislation that is very clear about adult safeguarding, and made sure that adult safeguarding was placed on the same on the statute book in the same way that children's safeguarding had previously been. So there was parity for adult social care as well, which is really important. I'm happy to explore adult safeguarding case examples from your own experience. And I know it's difficult on these meetings to be a bit interactive, but I do encourage you, if you want to, you've got a point or you want to come in with something, if you can turn your video screen on and wave your hand around, then I'll happily call you in to do that. I think we need to consider the impact of COVID on your safeguarding responsibilities, because you've been through incredibly the most difficult times that anyone could even think of, and that does have an impact on safeguarding in terms of access, people having access to family and friends, and to see where greater collaboration can be more effective in safeguarding people, and to discuss what makes a difference. And is there anything else that you'd like to be considered? So I'm going to kind of jump through these slides. I might miss one or two. I might stop and say, can I have a quick show of hands for those of you who are on video who know this stuff and think I should just go through? So if we can go to the next slide, please. So this is just a very fundamental one, and this is one that that I think is a really useful one for people to use. If you want to use it as part of your induction with your own staff, I'm happy, you know, that you can use this slide. It's about protecting an adult's right to live in safety, free from abuse and neglect. And I think the issues, when I've written safeguarding adult reviews, where that's when somebody's died, and the two that I've done have been done in connection with people who died in care homes. Actually, I think getting that understanding across that that neglect, it might be that they're taking care of somebody's physical needs very well, but they're not taking care of their emotional needs. So I think it's about that discussion which needs to be generated in care homes, which is really, really important. Importantly, people and organisations working together. So I think that's the important thing. It's about not keeping your worries to yourself. It's about sharing them. It's about working together. And as we've already heard from colleagues in health and other partners, it's about seeing what resources are at your disposal to work in partnership to find out if you're unsure about something. So next slide, please. I've put here a note, if you can go down through these straight away, that's right, thanks. A note on who can carry out an inquiry. That's a safeguarding inquiry, and it's section 42(2) of the Care Act. And sometimes a safeguarding concern may have been reported to the local authority, to adult social care, adult social services, and they come back and say, actually, we'd like you to carry out this inquiry, and that's perfectly legal. And it's important because you might be, it's called a caused out inquiry, and you might be, as a care home manager or a senior worker, the right person to make all the inquiries that will help people understand what's gone on and what needs to happen. So I just thought note in there would be quite helpful. Do you want to move on, please, Angela? I've also got some information here about what from the Care and Support Statutory Guidance into what objectives the inquiry has to meet. And this sort of slide would be useful for training senior managers or care home managers or deputies. I don't think it's a slide that you'd necessarily want to use with your frontline staff. If you can move on, please. Quite a few slides, so I'm sort of zooming through them and we can go back to them. Safeguarding during COVID, I think is really important, because I think there was lots of myths at the start about whether what they called Care Act easements, and that's where the government said, actually, there are some things we can put to one side during COVID because we know everyone's concentrating on COVID, and that we don't need to do this particular activity or that particular activity that's enshrined in the law. But the Care Act easements did not cover safeguarding. So that's, I mean, it would make sense to all of us, wouldn't it? You know, safeguarding is something that's really important, and you wouldn't want to ease that in any way or say we don't need to do that during the COVID pandemic. But the COVID impact on care providers was so massive. And in my experience, there were some safeguarding concerns reported which should not have been. And in one, not in the current safeguarding boards I chair, but in one local authority where I was chairing the board in the Southwest, there were reports that the ambulance service had reported a safeguarding concern because the care home, this was right at the start of the pandemic, weren't using PPE properly. And at the time, if you'll remember, there were difficulties around accessing sufficient quantities of PPE, but that was not a safeguarding concern. I mean, that was really over the top. And I think what we've learned is through the pandemic is that when local authorities actually treated care homes as their partners and worked alongside them in procuring PPE and in all the other advice, and when health services have started doing an incredible amount of work, NHS England had started the work with Restore2 and a number of other pieces of guidance for working for care homes, it actually felt as if care homes were being treated as partners and not as the other side, the dark side, and I think made a massive difference to how things were experienced. There have been concerns about the fact that a lack of visitors into care and nursing homes have impacted and to individuals living on their own who receive domiciliary care as well, have impacted on safe and quality care. because there's a view that if somebody's going in regularly, then everyone knows that someone else is checking on the person and they get good quality care. Now that may be a myth. It's been proved as there's evidence of that in some places, and so it's really important that during COVID, obviously, the extra attention is paid to where individuals have the opportunity to talk to somebody about how they're feeling and what's going on for them, where they might previously be talking to their relatives. Positive impact in that for many areas there was strong and lasting positive relationships, and I've certainly picked that up in the areas where I chair safeguarding boards and heard from care providers in those areas. But I think we need to think about the post-COVID impact and very seriously. I know the NHS is doing this in bucket loads with its staff, but the well-being of staff following the loss of so many residents and people who use services. You know, we're all human and we might be paid for doing a job, but actually you don't go into care work unless you really care about people, and the effect is devastating, particularly when you've lost a number of residents, and it's how staff are being supported during that time as well is really important. The loss of staff also, because some staff didn't want to work in the sector anymore, and that issue about the consultation on enforced vaccination for care staff is an issue. I know which the care home sector and the domiciliary care sector is very concerned about. In that, you know, will it mean that those staff who don't want to be vaccinated leave, and is it going to be more difficult for us to get staff to do the work? And I think those are actually safeguarding concerns as well, and we need to kind of bear in mind that you know, there are strong views either way on that, but I think it's certainly going to have an impact. So the next slide, please. So just a reminder slide here about making a referral to the local authority. The report and the refer will obviously be responsibilities of senior managers and care providers, but I think it's really important when working with staff that they know that recognition and that recording is very, very important. When I did a safeguarding adult review in a care home in another part of the country, well, the police had taken all the notes. They'd taken, and I had the opportunity to go to the bowels of the police station and sit and wade through all the notes in relation to a particular individual. And there were whole swathes of notes missing, particularly when you'd know it was a busy time and there's staff shortages, you know, over holiday periods. And so it's really, really important that you'll know all of this, that the recording is there and is right, and it was indeed referred to by the last speaker. So that's a slide that I'm happy for people to use as well. Next one, please. And this is something about the process to kind of really be clear about. It's not just a bureaucracy, it's about making sure we get safety plans. It's about learning from mistakes that are made. It's about even when there's been serious issues, the safeguarding adult review, the statutory review, the serious case review that takes place. It's about learning to see how we can do it better. And the issue, I think, for care homes is that we need to ensure that safeguarding adult boards are communicating to care homes where there is a serious case review, a safeguarding adult review, or where there is learning elsewhere in relation to the care provider sector, so that homes have the opportunity to know what they need to do. Because often the case is that there's not very good communication, and we need to recognise that needs to improve. So the next slide, please. Before I go on to this slide, can I just have a brief breather and say, does anyone have any questions so far? Just put your video on and wave at me and I'll call you. I can't see any. Angela, can you see any?
Sorry, I can't see anything because I'm sharing the slide.
Okay, I can't see anyone. Nobody's coming up. Okay, then. So these are just categories
sorry,
of.
Sian, perhaps if people have got any questions, if it's easier for them to pop them in the chat box, if they might like to do that.
Okay. I'll just so the categories of abuse under the Care Act. You'll know what all these are. If you want examples of these that particularly relate to your area and your home. I would suggest a conversation in your area with the Safeguarding Adults Board to say, how can we, you know, what can we do to improve our staff's understanding of some of these issues? Some are obvious, but the one area where safeguarding is on the increase is in neglect and acts of omission. And it's much more difficult to be able to determine neglect and self-neglect, and that whole piece around whether the individual has the capacity to make choices. And you know, I never forget when I was a very new chair of a Safeguarding Adult Board about 7 years ago, I went to observe another board in action, and this was in one of the London boroughs. It was Camden, and they had a Safeguarding Adult review of ZZ. ZZ was the acronym used for the individual, and this lady had huge pressure ulcers, was living at home, and used to she was very chatty with the care workers, and she used to choose to sit on a settee, and she'd often be saying, "No dear, I'm fine, I've had a wash earlier, leave me alone." And everybody assumed, this was several years ago, that they thought she had capacity to make those decisions, that actually that was her choice, and we always have to listen to the people we provide services for. And actually, in the end, the GP was called at one point, and I think the family member called the GP, and she was so badly injured through her pressure sores, she went to hospital and she subsequently died. And it was that whole issue about, you know, at what point do you start questioning whether the person is making wise decisions, and at what point do you start to think, actually we need to refer this to get some skilled assessment undertaken to make sure that we get the right treatment for this person. And I think, you know, that's in relation to home care. It will be slightly different in a care home, but these issues are all really, really important, and we need to make sure that staff have the stories and the understanding to be able to recognise them. And I think stories are really, really powerful to be able to explain some of these issues, and a communication with your Safeguarding Adult Board, I'm sure they'd be delighted to help produce some resources alongside care homes which give the stories that you can give to staff to help them in their training. The next slide, please. So this is just a slide that I've used this slide before, and if you are doing using these slides to your staff, you can use this and ask people to shout out, you know, in a group what their issues are. But I won't do any more on this now. Next slide, please. And these are some of the issues that you'll be able to use with your staff. You know these issues, I don't need to go through them. If we go to the next slide. And you know what's really interesting? I just think of one where I did some audit of some work in one of the local authorities in the southeast, and that was audit of social work safeguarding. And there was a couple placed in a care home, and there were particular issues regarding an individual and why they were placed there. And I saw straight away that, you know, kind of reading through the story, the assessment, actually there's clearly been domestic abuse between this husband and his wife, but nobody called it out, and they were living in the same care home, and the husband was kind of telling staff, oh, not to worry, oh, don't, she's always like that, you know, don't. And it's really important, I think, with this one, to get your staff to think out of the box, particularly where there are issues around a person's past experience, or if they are in a placement actually with their partner. So very important to think about. So don't need to go through them anymore, but you please do use these slides. Next one, please. So I wanted to put a slide in about information sharing, because there's a myth out there around the general data protection regulations that you've got to be very, very careful who you share data with. Let's be absolutely clear. If actually sharing information means that somebody is going to be protected from abuse, harm or neglect. You have it's in the public interest. There's vital interest duties to share that information, and it's perfectly okay to share that with adult social care. It might not be okay to, or the GP or the visiting nurse. It might not be okay to share the information with someone else who comes in, but absolutely any professional that you're working with, because the information sharing is important. And every safeguarding adult board will have an information sharing agreement with the NHS locally, with the police and with everyone. So it's important to note that. Next slide, please. And that's just going through, you know, why we need to share information. Happy to go on to the next slide. You can use that again. So persons in positions of trust. So increasingly, lots of safeguarding adult boards are now engaging with partners in ensuring that every organisation has a policy relating to persons in position of trust. And that's a policy that will be followed if a staff member or volunteer has been the perpetrator of abuse, and will advise what action should be taken. This might not necessarily be someone who's abused within your employment. It might be that something's happened outside of it, but I just wanted to mention it, that you should be aware of it, and you should be able to access a copy of a policy document or guidance on developing one from your local safeguarding adult board. It's really important. You can probably just adopt a local one, go through it, make it relevant to your particular circumstances and situation, but it is really important that your organisation has a PIPOT, as it's known, policy. Next slide, please. I just put some information here about the Mental Capacity Act. It's very basic information. If you can click again, I think the box on the right will come through. Yes, just so people have got that basic information. A lot of safeguarding adult boards are now doing guidance on the Mental Capacity Act in a very brief way, so that's easy to understand for the general public. So I can point out, if you have a look on it is in London, it's the London Borough of Lambeth Safeguarding Adult Board website. It's really, it has a really good guidance on the Mental Capacity Act, and you could download it or copy it and use it with your staff. I've got a question through there, and I'm just going to go to the chat to see if she says, hi, as a dom care provider, not all information is shared with us at any point unless we suspect something, and only then we are told previous relevant information. Karen, can I ask you to come in when I finish these slides? Can I call you in and let's have a talk about that, because I think it's a really important point you made. I'm just going to finish the slides and we'll come in. Okay, so there's some brief information, and the next slide, please. And what other legislation is relevant to adult safeguarding? And importantly, that UN Convention on Human Rights, the right to life, the right to be treated in a human and not in a degrading way, right to liberty, and the right to respect for private and family life. These issues are very, very important and should always be taken into account. Not necessarily in a kind of detailed application in relation to your practice in the care home, but making sure that if there's a safeguarding investigation, that they look at those issues and make sure that people are being, that those issues have been considered. So the next slide, please. So where can I get more information? I thought this might be quite helpful. So ADAS is the Association of Directors of Adult Social Services. They've got multi-agency policies and procedures for adult safeguarding, so have a look on their website. Research in Practice, which is based in the Southwest, based in Devon actually, they've got lots of information. There's information on your local Safeguarding Adult Board website. And so if you just go usually onto the local authority where you are, and then type in adult safeguarding, it will direct you either to a separate website or a part of the website that's hosted specifically for adult safeguarding. Community care, the Care Act and statutory guidance, that's on the Local Government Association website. and the Social Care Institute for Excellence. Now, they've recently developed new guidance on safeguarding in care homes, and I was a consultee in relation to that. My view was that it was very thorough and very, it kind of had very comprehensive. It had all the information there, but I don't think, I remember as a care home manager, when you receive 297 pages of guidance on something, it's actually really quite difficult to sort of download all of that into your brain and think, actually, what can I use from this that's quite helpful? But one of the recommendations arising from that guidance, and the guidance is from NICE, not Sky. I've written that in wrong, so I'll change that slide and send it to you before you put it up on the website. The National Institute for Clinical Excellence. They are saying that every care home should have a safeguarding champion, or every domiciliary care agency should have a safeguarding champion who can be, supportive in helping staff. And some of you I know will have that already. So I think that's my last slide, and I'm going to add the NICE information to it. Apologies for not putting NICE in on the new guidance there.
It is the last slide, Sian.
Thank you.
What I'll do is I'll stop sharing now, and then we can get to the chat.
Okay, so thank you. So Karen, do you want to come in?
Can you hear me?
Yes, I can. Yeah.
Yeah, the amount of times that, for example, a package of care will come up, we take on that package of care. Mm-hmm. I've got a fine example, and even almost a year later, the problems are still going on. I go in, do an assessment, something's not quite right. And then it's not until I ring up, ask a few questions. Oh yeah, by the way, there's been 18 previous safeguardings raised, etc., etc., etc. And it's like, why are we not told this information, or this information which is still very much relevant?
Absolutely.
Situation still going on. Why are we not informed of this?
Absolutely, and you should be. You might not be given. So, for example, if there was a safeguarding concern about the person you're caring for, one of their relatives, and their relative is not around anymore, you might not be given the detail, but you should know at the very least that there have been some safeguarding concerns and that you need to be aware of it. And what's really important, and you'll know this when you're working with your staff, because I remember it when I used to work with my staff, it's about saying to staff, look, please don't just share this information with the individual, but you need to be aware of this so you can keep your eyes and your ears open to anything and come back to me as your senior to alert me as to you've got a concern about something. And I think that's really important. So I think you should go back and say, at the very least, we expect to know.
Oh, and I have done for the last 3 years.
Good.
But it is still, a fine example, I've just had another one come on. To actually find that they've supposedly done a recent assessment. Now on this particular one, which is a one-off, they've not done this before. They put on an assessment that they've done from 2018, 19 and 20, saying about how there was a violent partner in the house with firearms, etc., etc. They've done an assessment, but now there's no talk of this partner, whether he's still there or not. And I'm actually still trying to find out whether there's this partner. I'm actually going to meet this person tomorrow.
Karen.
Hi.
Yeah, hi, Karen. It's David. David Small. Yeah, as we know each other. By all means, come back to me offline on this, and we will see if we can support and help you on this.
That would be brilliant, David. Thank you very much.
Because I think it's really important that as care providers, you're treated as partners by the local authority that commissions your service. And we have seen, as I said, in the slide on COVID, we have seen a big improvement in that because, the needs must. But yes. Absolutely. So great that Care and Support West is able to support you. Brilliant.
Lovely. Thank you very, very much.
Thank you, Karen. Thanks for raising that important point. Anybody else got any thoughts or questions? Was it helpful, or, I can answer other questions off the top of my head for people who've got them if I haven't covered something you thought was going to be covered.
Sian, it's Angela. While other people think about that, I'm conscious that there are quite a few people on this call who are managers of non-residential services, so supported living, home care.
Yeah.
Could you tell us a little bit about stories, about what you mean by staff knowing the stories? Can you elucidate, please?
Oh, yeah. So we all know we've got to do our safeguarding training, and everyone does a different level according to their role. And I think that's great. And, you know, people do that, and you do refreshers and all the rest of it. But I think the most powerful thing to use in working with staff to understand safeguarding is to tell stories about individuals. So as a chair of a safeguarding board, I have what I call a personal safeguarding story at the start of every board. Now, I'm going to pick on one now to give you an example that comes from supported living. So this happened when I was chairing Devon board, and we had a young man with a learning disability with Down syndrome who reported a safeguarding concern because his care had been commissioned. I mean, I think he was entitled to about 15 hours support, and he lived in a complex where a number of other people had various amounts of hours of support. And I know sometimes, I used to be a supported living provider, so I understand that it can be difficult to manage, you know, making sure everyone gets the right hours. But what he was finding was that he wasn't getting his 18 hours, and that there was some other residents who had some behavioural issues that were getting more hours of input from staff. And he felt he wasn't getting the support he needed. He needed to go to the dentist. He had a number of other issues. And he raised that with the support of his, he had a support worker in another service he used to attend, and his mother, who was very active in his care, who raised a safeguarding concern because they said, actually, let's call him John. John isn't getting the support he needs. He's got care and support needs. And actually, this can amount to neglect or an act of omission because he isn't getting the support he wanted. And John came and spoke to us with his social worker, and with his mum was sitting there. His mum didn't say anything, and taught us. And it was incredibly powerful to listen to John, to hear how he felt and how he was supported to express how he felt. And even though it wasn't a deliberate act, shall we say, of where a safeguarding intervention was needed, it resulted in that care provider actually thinking, actually, we've got to get this right. We can't be using John's hours to support Jason because Jason's got behavioural problems, and we need to go back to Jason's social worker and say we need more hours if that's the case, you know, to support Jason in his behavioural problems. So, you know, when you tell a story with an individual, or particularly if you have an individual there to tell a story, you remember their face, you remember them, you start to see a picture of them in your mind. And, you know, we're human beings, we relate to people. And I think when we've got pictures of people and their stories, they can be so powerful in helping us learn. So let me give you another one. And this one's from a care home. This is a safeguarding adult review I wrote. So Elsie, let's call her Elsie, was a very bright lady. She was a qualified teacher. She had an interest in politics and current affairs, and she lived in a nursing home in another part of the country where there were staff shortages, and where there were people that the manager had accepted for placement who had such severe needs that, well, again, all the staff got sort of often transferred to the people with very dependent needs. Elsie had very dependent needs as well. She had pressure ulcers all over her body, and one of the members of staff actually established a relationship with her and talked to her about the issues that she liked to hear about. And she would allow that member of staff to turn her. She would allow that member of staff to deal with the painful dressings and remove the dressings and the rest of it. But the other members of staff, she said, I just feel neglected. They just look in the door and say, are you all right? And they're off before I can answer. So that story shows how I think if you develop a relationship with someone, A, it's better for you as a staff member, but B, it's better for the resident because they then have confidence in you and will allow you to deal with things that otherwise they won't. And some of the staff there said, oh, she won't allow us to change her dressings. And I mentioned before that there was no notes. You know, there was sometimes weeks where no notes were taken, or there was a paucity of notes and it just said all care given, all care given. You know, that's not what we want to know. You know, if a month earlier it had been that she needs to be turned, you know, 4 times a day because of her pressure ulcers, and she needs her dressings changed 3 times a week, then that needs to happen and it needs to be noted. So it's actually giving a story and trying to, you know, learning about. You'll remember Elsie, the teacher, when you go away from here today, probably, and you know, it's putting a whole flavour around a person. It's getting to know who they are, who the person is, and it helps to help people understand, because everyone says, oh, if that was my mum, I wouldn't let them go there, because it might be different for their mum than it might be for someone else. And some people I know can't relate that to, this is my job, but I wouldn't let my mum go there, and they can't relate what they need to do to change their job. And that's not in all places. And I'm sure all of you, because you signed up with an organisation like Care and Support West, you're actually really committed to providing high quality care. It isn't the case everywhere. So actually using stories is very, very important to highlight to people. So I've given you some slides, and if you want to say, actually go to your local safeguarding board and say, have you got some stories? Go to the business manager of the board, that's the person to speak to. Have you got any stories that you could share with us that's relevant to our service, anonymised, that we could help to use in training our staff? They'd be delighted to share those with you. And for anyone who's in Bath and East Somerset, I chair that area, so happy for you to come to me.
Well, there you go, everybody. There's an offer. Thank you. I share your what can I say? This sense that, you know, telling stories with human beings is as old as human beings being on the planet, and it's a very, very powerful way of building meaningful relationships and remembering stuff. We remember stories, and that helps. So the chat box is looking quiet. I suspect everybody is deep in thought. Sian, thank you so much for your presentation and for all of that information which you're so generously offering people to use themselves with their teams. So we really appreciate that.
I'm really happy, Angela, if you want to, when I redo that slide, so the last one has got the nice on it, I'll put my email address on the front. And if individuals would like to email me and they've got a query, I'll do my best to direct you to the right person or answer that query. I'm really happy to help. No charge, you know, that's just because I'm passionate about getting it right here. And I'm passionate about good quality care in residential and home care, which is an area that I've been responsible for.
Thank you. I've just seen that Mohammed has said, can he ask a question? Mohammed, yes, please come off mute and ask your question.
Oh, thank you very much. I really appreciate it. Thank you very much for the slides that you share with us. I have a question. We are a dom care provider in here at Bristol. So in terms of information sharing, I just want to share with you an incident that we had recently. I'm not sharing any names or anything. It is one of our service users had an accident. I think the carer wasn't using the manual handling proper in terms of according to the social services. So the social services contact us, and they ask us to investigate this matter. We did investigate, and we contact the service user. The service user said nothing has happened. Nothing had happened. The carer was trying to help me, and my leg hit on the wall. So we said, do you mind? Can you please give us your consent to put this as a safeguarding? He said, no way, no. So we called back at the social services. We give them the information. We send them an email. So one of the social workers contacted us, and she said, can I have the full details of the care worker who visited that client? So we said we have investigated the matter. We follow our procedure, policy and procedures, and our investigation and procedure. I don't know. So it was a bit new to us to give hand out all the information, like a date of birth, address of the care worker, and nothing major has happened when we investigate and contact them. So what's your thoughts on that? Thank you.
My thoughts on that are that I think when you go to the service user, it's sometimes better, rather than say, can you give your consent to us reporting this, it might be a better way of doing it to say, look, we appreciate that the manual handling hasn't gone in the way it should be. We know you bashed your leg, but we know you weren't hurt. But we have to let our social services know that this has happened, because we are very open and transparent, because we want them to know that we're very honest and we share information. So I'm going to send that information in, and it may be that they want to talk to you, but if you don't want to talk to them, you can tell them everything's fine and you don't need to talk to them. And I think it's about how you put it, rather than say, please give me your consent in the first place, and saying, actually, we need to tell social services because they pay us to do, to deliver the service, and we have to, work in this way or whatever. I think that's the way of doing it. And I think the way you then write the referral, when you send the referral in, is to be really clear and say, we talked to the individual about sharing information. Even though we said we had to share it, they were adamant that they didn't want to take it any further. But these are the details. And I think that if I was the social worker sitting, well, I'm a social worker, but if I was the social worker sitting on that desk, I would love it, Mohammed, if you actually said, and we spoke with worker XYZ, and we've spoken to her about her manual handling practice. We've reinstituted some manual handling refresher training for her or him, and we're monitoring that through supervision. I think if you're offering all that information, they're less likely then to want to go and dig and find everything out. So it's about the quality of, not the quantity necessarily, but the quality of the referral you make and the way you speak to the individual when you say you have to actually pass this information on. Does that help?
It is help. Thank you very much. So when do we need to share a carer information to the social services?
Well, if they ask you to, I think that's not a problem. If the carer's made a mistake, and it's an act of omission, isn't it? But you need to be showing the social services, when you're referring it, that you think that's serious as well, and you've dealt with it, and you've got an action plan, and you're dealing with it in supervision with the worker, and you're retraining them. You need to show all of that. So I give you, I had a situation with a member of staff when I was an independent care provider, who, there was bruising to it was a member of staff who worked on a night shift in a care home, and the lady had bruising, and there was no doubt that actually where it came from, because nobody else had had contact. So when I made the referral to social services, and this was pre-Care Act and so I referred, it was the adult protection team at the time. I said, look, this has happened. This is the full report of what I've done to date. We've suspended the worker. This is what action we're taking now. This is the investigation. I put all that detail down, and they came back to me and said, wow, thank you. It's really good. You've sent a really thorough referral, and you've given us confidence that you know what you're doing. Please let us know the outcome. And they didn't want to know the detail. So I think if you share all the good practice things that you're doing, and you demonstrate an evidence that the person's going on training again, it's being picked up in supervision, and the support that you're offering to the client, then I think that's what they'll want to hear. They may still want the support workers' details, but then you need to talk to them and say, and support them through that as well. If their action was not serious enough, that that you actually believe they've done something, you need to support them through that as well. Yeah.
No problem. Thank you very much. I appreciate it.
Thank you for the question, Mohammed. Thank you, Sian. Okay, I think we're probably there now, Sian. Thank you so much.
Thank you.
And thank you for offering to take any private queries offline that people may have. So I'm going to turn off the recording. Thank you all so much for joining us this morning. Thank you to our great speakers. It's been great to have you here sharing such really useful information with us all. Thank you. We look forward to seeing you at the next one. The next scheduled one is the 9th of November, which will be our AGM and a workshop featuring the Get You Better musculoskeletal app, and Kathy Chilliston on something called Time to Reflect. So I'll leave you thinking about what that might be. We may have another one in between. I'll come back to you on that. Look out for the info. But thanks, everybody.